there, I'm Dr. Thomas Martin from the University of California in San Francisco, and we're here today with Blood Cancers Today, discussing bispecifics and how we incorporate these new novel therapeutics in our treatment armamentarium for relapsed multiple myeloma. And I'm joined with several esteemed colleagues.
Hi, I'm Angela Dispenzieri, Mayo Clinic, Rochester, Minnesota.
Hi, Ajay Chari, recently at University of California, San Francisco as well.
Ajay Nooka from Emory University.
So I want to ask one more question before we talk about operations of the bispecific, like operationally how you've enrolled patients and how you've basically rolled out this therapeutic for your institution. But one question is, where do you think the optimal place for this therapy is going to sit? Like, where do you think bispecifics are going to have their best role? I'll start with you, Angela.
Oh boy, I don't know. I mean, I think the strategy in myeloma is, earlier is better for everything, and that's the way perhaps you're going to cure people. But I just don't know. It's sort of, do you do everything kind of at once and sort of use everything up, or like what's the intelligent way to go about it? I like them a lot in the relapse setting, in truth, because they are so, convenient in the sense of off the shelf, but it's hard for me to predict what the next 10 years are going to bring, 10, 15 years are going to bring.
But it's exciting.
It
exciting
is. Oh,
think
without a
about the whole
doubt.
thing.
Oh, it's amazing. I mean, it's a good problem. I tell patients, the good news is there are a lot of options. The bad news, there are a lot of options, because you
Right.
can't be dogmatic. You
Right.
can't say, okay, we're going to do this because this is the answer, because so much is changing. And so.
All right, how about you? What do you think?
I think one of the challenges is currently we only have single-arm studies. And for the ability for drugs to move up, you need to understand relative to a control arm what the value add is. So I think, and if we look at examples of drugs that moved very quickly up front, DARA is a great example, right? Very easy, predictable toxicity is very combinable, so blew up front. Carfilzomib still doesn't have a frontline indication, right? So, and it just shows the complexity of the dosing, the schedule. I think where I see bispecifics going up very early is the unmet needs, right? So extramedullary, renal failure, high risk, areas where our current drugs are not enough. Those will get moved much faster. But for the standard risk, I think we need that randomized data to make sure, for example, that infectious deaths don't offset any other issues.
Yeah.
Yep. Any other thoughts?
So I think what Ajay has mentioned before about the T cell fitness. So when is the most optimal time for the T cell collection? Probably is going to play a huge role. Then we may not have any data as we speak, but we can, if we can take the surrogates from Bruno's data. Bruno showed in the smoldering myeloma patients where the T cell fitness is the best is after starting the treatment, even in smoldering myeloma space, where the T cells are really healthy at the 8-month or 9-month mark. I would argue this in two ways. Number one, is that related to the choice of the treatment that we make, or is it related to the effect of myeloma on the T cells? So both of them, right now, if we take the best analogy, we collect the stem cells after a brief period of induction therapy. And that is the time where we have the lowest disease burden. And at the same time, we probably could collect the healthiest CD34 cells for our stem cell transplant. In the same way, could that be the right place where we could collect the T cells with an intent to use them at a later stage? And later stage in the sense, so even in the maintenance phase, there's a huge opportunity for us to explore and expand the benefit of PFS that we're already achieving. So I feel like there's a huge amount of potential in that space too in the future.
Excellent.